Good afternoon. It's my pleasure to be here and discuss with you the interest and limitations, honestly, of the inferior vena cava and superior vena cava in guiding the fluid therapy in critical ill patients. And because several of the concepts have already been discussed with the two previous speakers, I think this is uh, quite obvious that we will have to take into account several aspects, including the prediction of the response of fluids, but also the risks associated with giving fluids. I will not develop too much the risk associated with fluids, but it's quite obvious that what have been said by the others, including the right ventricle aspect and including, of course, lung aspects, is something to be debated. So what we have is we need to try to assess the response to fluids, and especially to try to detect the patients who may benefit from fluids, but also, of course, knowing that when we do this, we begin by having a problem for which we think the potential solution may be giving fluids, of course. Otherwise, we do not need to go in that direction, and we have always to weigh the benefit and risks of all these aspects. We can do a lot of preload measurements. We know that the static measurements, pressures and volumes, do not predict the response to a fluid challenge. And this is true for the volumes assessed here by the left ventricular and diastolic area, and as well as many others. And we just know that each patient has his own Starling relationship, and that we just have the extremes that may be somewhat predictive, but in between, which is reflecting the vast majority of our patients, unfortunately, we cannot really predict the response of fluids. We should nevertheless not neglect the information provided by these preload indices, because just the risk associated with fluids will be somewhat guided by this. If we have a very low preload, even if your predictor is not very accurate, the risk associated with a wrong decision will be minimal. On the other hand, when you have a patient with an elevated preload, then being wrong in your prediction may have much more catastrophic issues later on. So we need indeed to put ourselves in the context. And yes, I do not measure the preload indices to predict the response of fluid, but I measure these before predicting the response of fluid to know where I put my feet, what are the risks associated to fluids. So we go indeed for these preload dependency measurements, and this is really something we recommend, and I was in the panel when we recommend this for the management of fluids, and I think this is very, very important. And so we can do a lot of ways to try to measure the preload responsiveness, and Xavier Monet did already a great job discussing the interest and limitation of all these. And I will go in more details for the interest of the respiratory variations in vena cava size. And then we are back to what was already covered somewhat by Dr. Antoine Verbajon, is the Guytonen physiology, and it is really using the echo to try to evaluate this. I think it's really important to remember this, that indeed the venous return is determined by the gradient between the mean systemic pressure, which is, of course, the pressure in the central vascular system, and the right atrium. And the larger this gradient, the larger the venous return. And when the gradient is really small, then we have a stop flow that can occur, depending, of course, on the value of the mean systemic pressure. The higher the mean systemic pressure, of course, the higher the change that this gradient will be null on the right side more than on the left side. So we have indeed this difference between the right atrial pressure and mean systemic pressure, which is really critical for determining the venous return curve. So what is the influence of respiration in these conditions? So everything, of course, depends if we are in mechanical ventilation or spontaneous ventilation. But here we are in mechanical ventilation. And so what we have is that when we are in expiration, we have this apparent right atrial pressure. When we increase the intrathoracic pressure, so the total pressure applied to the vascular system in the thorax will be increased somewhat so that the gradient for the pressure for venous return will be decreased, because indeed this is just the impact of the increase in the intrathoracic pressure. And so even if the transmural right atrial pressure decreases, what the venous the force for the venous return C is that in fact the pressure, the intravascular pressure is effectively increased. So we need indeed to make the difference between the true preload of the right ventricle and what is limiting the venous return to the thoracic area. And of course, we can mix this with the cardiac function curve so that we have the effective cardiac output. So when we have this increase in the intrathoracic pressure, we have then the decrease in cardiac output that occurs in these conditions. And of course, if we give some volume, we can increase then the cardiac output in these patients. So can we look at the inferior vena cava and superior vena cava to predict the response of fluid? Well, we remember that the ventilation induces cyclic changes in intrathoracic pressure. That basically the mean systemic pressure will be stable over the respiratory cycle. So the gradient between the mean systemic pressure and the right atrial pressure, intravascular one, will vary according to the state of volume responsiveness. And indeed, what we have is that we have some changes in the intrathoracic pressure. The pressure in the right atrium, the gradient will be decreased in the fluid responsive during this the increase in intrathoracic pressure, while in the non-responders, it will not, because the patient will have a high intravascular pressure. And this is nicely shown in this very old data from 60s, showing that mechanical ventilation induced cyclic changes in vena cava flow. And we see that indeed there is initially a decrease in this vena cava flow that occurs just at the onset of inspiration. And of course, during expiration, it goes back to the previous value. So there are cyclic changes there. How can we detect this with echo? We'll discuss later on. But so if the patient is preload responsive, the increase in the intrathoracic pressure and decrease in vena cava flow will be accompanied by some cyclic changes in vena cava diameter by upstream stagnation of flow. If the patient is not preload responsive, the changes in vena cava flow and diameter will be minimal in these conditions, so that indeed we will see almost no changes in the diameters there. And so indeed, we then need to think at what occurs in spontaneous ventilation. Well, we have an increase in the gradient for the venous return that occurs during inspiration due to the decrease in intrathoracic pressure. And how does this translate into changes in cardiac output? Well, when we are on the when the gradient between pressure gradient is quite high, in this condition we will have a change in cardiac output, which is not the case when the gradient is not high. So what we have here again in spontaneous ventilation, because when we look at the diameter and not the flow, of course, in the inferior vena cava, in patients who are volume responsive, we will have there a decrease in the diameter of the inferior vena cava, which is not the case when the mean system pressure and right atrial are high, and so the gradient is minimal in these conditions. On the other hand, when we have uh, mechanical ventilation, as we mentioned, we will have there a dilation of the inferior vena cava occurring only in the fluid responsive mode. So conceptually, we can easily separate fluid responders and fluid non-responders. So what is it in practice? So what do we see in practice in these patients? Well, we have these data, and Antoine Verparon, who is still there, knows very well this data because he helped to generate this data. We can see that indeed we see this dilation of the inferior vena cava during the inspiration in this preload responsive patient. And some groups, including again the group from Bicêtre, and also including the group from Bicêtre, and including the group from Ambroise Paré, so two groups from Paris, almost at the same time, described the same aspects, that the respiratory variation in inferior vena cava diameter can be helpful to guide the fluid therapy and to detect patients who will be fluid responsive. And so one of these trials is this one, and we can see that indeed we have minimal changes here in inferior vena cava. We can see that indeed there is no change in cardiac output after volume expansion. Here we have this vena cava variability during respiration, and you can see that indeed this patient increase his cardiac index after administration of fluids in this condition. And when we look at the individual values of the cardiac index, we can see that indeed most patients here with minimal variability in inferior vena cava did not change their cardiac index, with basically two exceptions here, while most patients here with a significant variability in their inferior vena cava indeed increase their cardiac index in these conditions. And interestingly, they also related the level of variability of the inferior vena cava to the degree of change in cardiac output after fluid expansion. So the more there is variability in inferior vena cava, the higher the changes in cardiac index will occur. And I think that the concept there, I think, is still very important. We can discuss what will be the best cutoff, and we will do this later on. But remember that if we are very close to the cutoff, the impact on cardiac index will also be relatively modest. While when we have huge changes in diameter during ventilation, then indeed we will also have significant, clinically significant changes in cardiac index also. So this is also something very important, that it is not trivial to be close to the cutoff, because then when you are close to the cutoff, the changes in cardiac output will also be somewhat relatively limited with fluids. And this group and others have shown indeed that the variability in inferior vena cava is very helpful to predict the response of fluid, with very good ROC curves in these patients. The other group also shown exactly the same aspect, with again some relatively good separation between responders and non-responders. Importantly, we need to look at the maximum diameter and minimal diameter. And we can see that if we look at the maximum and minimal, there is some significant difference. But for the individual prediction, well, this is not very good, because indeed we can have here patients with still dilated inferior vena cava and nevertheless responding, and patient with non-dilated inferior vena cava and not responding to fluids. So the absolute diameter again is not enough, because it just reflects again the gradient between the mean systemic pressure and the return in the thorax. But when we will think later on what are the risks associated with fluid, remember that the more the vena cava is dilated, the higher the risk of edema in the periphery. So the balance between the risk and benefit is, of course, lower in these patients here, even though these patients will respond to fluids. So this is something, again, to pay attention to, of course. But again, the prediction of response to fluid was not bad with this. And again, a relatively good correlation between the changes in cardiac index and the changes in the variability in inferior vena cava in these patients. So the two trials were very similar in design, similar in their conclusions, and so probably showing that the concept itself is very good. Inferior vena cava in spontaneously bracing patients, well, again, as we discussed, we should expect here collapse of the vena cava during inspiration. And we see that at the end of expiration here, there is a collapse here of vena cava, again, inflating during expiration when venous return can come back again. And these are some examples here of inferior vena cava collapsibility here and dilation here in these other patients there. And when we look at some data, we can indeed see that the respiratory changes in inferior vena cava diameter can predict fluid responsiveness in quite good discrimination in patients spontaneously breathing. And you can see here that this patient indeed had a difference here between responders to fluid and non-responders to fluid also. We'll discuss later on what is the best cutoff to separate both, but we already can see that it seems that the confidence interval for the non-responders here is somewhat broader than it was for the mechanical ventilation. And this was again found here by the group of Xavier Muller in Nîmes, in the south of France, where they also observed that there was some significant difference between responders and non-responders, but the cutoff was not 12 or 20%, it was much higher. So that indeed, when we have a very high variability, most patients will respond to fluid, even though there can be some exception, as we can see here. When there is minimal variability, most patients do not respond to fluid, but still, some may still respond to fluid. So obviously, it is less accurate in spontaneously bracing patients compared to what it can be in patients under mechanical ventilation. So it is a really simple index to obtain with ECO. I think that you need really very minimal training to do it relatively correct. It is correct even in the presence of arrhythmias and high respiratory rate and right ventricular failure, because indeed these patients with right ventricular failure will have dilated inferior vena cava and no change in vena cava diameter, which is not the case when we look at post-pressure variation or stroke volume variation in these patients. We nevertheless have several prerequisites. Ventilation should be with a large tidal volume. Again, if we have a minimal tidal volume, there will be minimal changes in intra-thoracic pressure and hence in vena cava diameter. Mechanical ventilation is probably much better than spontaneous ventilation, and we really have doubts about spontaneous ventilation. Intra-abdominal hypertension, as shown by Xavier Monet, is a major limitation. Contraction of abdominal muscles. If I contract my muscle now, I will squeeze my vena cava, and this is just artificially changing the diameter and not related to any fluid responsiveness.
Which muscle?
Big question. What is the best formula? We can see that in literature, we have different formulas. Either looking at the difference between the maximal and minimal divided by the maximal value or divided by the mean value. And no trial have really compared what is the best formula to use at the bedside. Well, it's difficult to know exactly, so I will not pronounce myself, but it seems nevertheless that using the maximal value is probably better, because when we do the mean, we still introduce a second error there. So it's probably better for just the risk of errors to just you have one measurement there. What about the superior vena cava variability? Well, this is even more interesting because the superior vena cava is entirely in the thorax. And we can see that indeed variability in superior vena cava is associated with fluid responsiveness. I will not go too much into the detail because this has just been shown by Antoine Verbaron in his previous talk. So it is indeed exploring the relative contribution of the different pressure, the mean systemic pressure, the pleural pressure, and the right atrial pressure. And indeed, when we will giving fluids, we'll further increase this gradient in patients here who are fluid responsive, while the gradient here, which is already quite large, will be minimally altered when indeed we give some further fluids. So detecting the patients where indeed giving fluids will increase the gradient between right atrial pressure and mean systemic pressure is really crucial. That's why indeed looking at these patients with large or significant variability in the vena cava diameter is really crucial in these conditions. And this trial was indeed very good here because indeed there was a clear separation between patient responding to fluids here and the patient not responding to fluids here. How to measure? This becomes to be a crucial point because measuring the inferior vena cava diameter is easy, but where should we measure it? Well, we can measure the vena cava on different on this length, but it's usually considered that we should do it closer to the diaphragm, if possible, above the hepatic vein, where it is less sensitive to squeezing the abdominal muscle and also to the translation artifacts. And indeed, we need to be very careful. And this was nicely shown in this cartoon here, that we need to be careful just not to cut the vena cava on this side, because indeed the diameter here will be false. And of course, changing during respiration from the central to the lateral point will falsely demonstrate some respiratory variation. The same is true if we apply some angle here during the ventilation. And so that if we change the angle of the cursor during and there is some movement of the vena cava and the diaphragm, then indeed we can also generate some changes in diameter here that will be falsely interpreted as changes in vena cava size. Also, what is the best way to look at it? Should we be perpendicular to the vein, or should we use it this diameter here, which is the mediolateral? Well, if we look at the movement of the inferior vena cava during ventilation, there is minimal changes in the mediolateral diameter, which remains relatively small. The vena cava is flattening, but remains exactly laterally more or less the same. So we should do it by doing really the craniocaudal evaluation and not the mediolateral one. For the superior vena cava, we have, of course, to use the upper esophageal view, which is obtained 25 to 30 centimeters from the mouth, and to look at the bicaval view, for which indeed, in these conditions, we try to cut the vena cava here. So we are in the middle of the inferior vena cava, and then we look at here, just at the entrance in the right atrium, and just usually close to the trachea. So we have to try to be as far as possible from the right atrium. Then, of course, you need the transesophageal route. Can we do it without it? Well, this was described by Antoine Verbaron and some of his colleagues in this concept letter to intensive care medicine. And that indeed, by applying the parasternal approach and by angulating somewhat the probe until the direction of the vena cava, we can indeed see here the aorta and then the inferior vena cava. Well, it is achievable, but it's not really as easy as we can think. I mean, because unfortunately, and especially with mechanical ventilation, it's not uncommon that, especially during inflation, the lungs comes in front of the probe, and that we lose the view during inspiration. So even though detection of vena cava is feasible in half of the patient, during inspiration, we often lose the view. So whenever it is feasible, it's interesting to see that indeed the concept, of course, of the inferior, superior vena cava variability to predict response to fluid still remains valid and can be used, of course, in these conditions. Can we use some other veins? Well, some people have described the internal jugular vein variability. And for this, as you can see, they use a vascular probe. They apply it to the jugular vein at the 2 or 3 centimeters above the subclavian place. And what they see here is the jugular vein, and they look at the respiratory changes. They obtain it in patients who are fluid responders and not in the other one. And there was indeed some very nice correlation between the changes in inferior vena cava, jugular vein, sorry, and the stroke volume variations in these patients. It's okay, but this area is very, very sensitive to pressure. And this is really the most critical aspect, is just ensure that by applying a small pressure on the neck, you do not alleviate any change there. So we know already this when we practice the use of this ultrasound to insert catheters. We know that it is very easy to compress the vein, especially in patients who are hypovolemic. And so it is in these patients is probably the most useful to look at. So it's not always easy to do this kind of things. Putting everything together, well, indeed, when we look at the meta-analysis for the inferior vena cava in patients with mechanical ventilation is good, but it's not really optimal. I mean, it's 0.7 something. So it's not as good as we may perhaps expect. And superior vena cava is definitely better than inferior vena cava in these patients also. And so this is another trial already shown by Philippe Vignon, showing that the superior vena cava, inferior vena cava, and we can see globally the ROC curve is much better with superior vena cava compared to inferior vena cava. And this was in all patients that were all under mechanical ventilation. So the same better aspect to look at inferior vena cava, of course, in these conditions. And the last point I would like to discuss is what cutoff should I use? And for this is something we need really to think at, because it's far from what we usually look by just the Yoden point on the ROC curves when you say, okay, this is the best point. No, this best point can vary because we don't have something like a yes and no approach with the cutoff and below the cutoff, no response, above the cutoff, a response. It is much more a progression. And it's true for stroke volume variation, for inferior vena cava, superior vena cava variation also. It's the likelihood to respond to fluid increases with the increase in the variability. But so there is minimal changes with a low cutoff. There is a maximal change with a high value here. And so this is also where we conduct this gray zone concept, where indeed we have some area when it will be much more difficult to really conclude whether or not the patient is fluid responsive or not. And we can then optimize the sensitivity and specificity. And then the cutoff will be different. And I don't go into the details here. You have the reference, can look at the data. But the most important aspect is that when you optimize the specificity, this is really when you want to be sure that there is minimal risk, when there is some risk to give fluids, that you will not give fluids when the patient has the change not to respond. While when you optimize sensitivity, this means that the risk of fluids are minimal and you don't want to lose any chance to give fluids in these patients. So we need to adapt ourselves to the concept and not to use a specific predefined threshold value. And so to conclude, respiratory evaluation in superior vena cava predict fluid responsiveness very nicely. However, these almost exclusively need to be obtained by transesophageal route in mechanically ventilated patients, so a very tiny subgroup of patients. Respiratory variation in inferior vena cava obtained by transthoracic view is quite easy to do, but their predictive capacity to predict fluid responsiveness is lower than the superior vena cava, especially, unfortunately, in spontaneously breathing patients. And with this, I thank you for your attention.
Unmute yourself, Walid, please.
Sorry. So thanks so much for this comprehensive, collective overall view on IVC and SVC variability. Until we get more questions, I have a couple of questions for patients that we see not infrequent in ICU. The first one is a patient with an open chest post-cardiac surgery. An open chest, do we still assess the SVC variability or not? And that's the first question.
So in open chest, the changes in intrathoracic pressure will be lower. It's not that do not exist, these are lower. So probably the threshold will be altered. But the concept behind it is still there. If you see some dilated veins with minimal variability, probably minimal change, your patient will respond. If you see some relatively small vena cava, and you see that during insufflation there is still some variability, yes, your patient is likely to respond. Then when you see no variability in a small vein, then probably you need to look at other tests, because then you are not really sure that you can really predict the response to fluid in these conditions.
Perfect. Not infrequent, again, we see pregnant ladies and we cannot assess the IVC, and there is some talks about the parahepatic or mid-axillary or anterior axillary line assessment of the IVC. What is your input?
Well, I think that in pregnant women, we should not look at IVC, whatever is because the intra-abdominal pressure is really and the volume taken by the baby is really the limiting factor. And so the compression of the vena cava is also playing a role downstream, the way we assess it. And I think it's really better to look at the superior vena cava in these conditions. Maybe jugular veins can be quite interesting in these patients, provided indeed that we do not apply pressure in these conditions.
Okay, so reaching this point, if we're talking about jugular veins, what is the position for assessment? Is the patient sitting 45 degrees, or is semi-flat or completely flat? What is the proper position?
Well, this was not described, but I don't think it makes a major limitation, because it is assessing the response in the condition you are evaluating the patient. So if you put the patient at 45 degrees, the patient may be fluid responsive at that time. If you put the patient flat, it may not be responsive anymore. But this is just what we explore by doing the passive leg raising test, of course, when we give some volume, intrathoracic volume. So if the patient is sitting and we see some fluid responsiveness assessed by different factors, then indeed the patient is in these conditions fluid responsive.
Okay,
we are behind the time. 2 minutes
okay.
Now we're behind the time.
Perfect.
If you allow me just to conclude the session.
Yeah, if you give me 30 seconds, please, I'll just say something, Dr. Ashraf. So, Prof. Daniel, thanks so much. There is loads of questions in the Q&A section. If you have a few minutes more to answer them in typing format, and we'll keep a record of that as well. So thanks, and the microphone is to Dr. Ashraf Tayyar, please.